Okay, so what I do is I go ahead and inject 1 in 60,000 adrenaline onto the lateral wall. If you see, this is a bit high mag that I'm showing you. This is septum and this is the lateral wall. You can see it is quite, you won't see any space into that one. And what I'm doing now is I'm very gently packing with phenylephrine gauze, soaked in phenylephrine, 0.5% for the adults and 0.25% for the pediatric age group. So it should be a bit meticulous. At the same time, it should be very, very gentle. If you abrade these surfaces while doing this, then you will have a synechiae. So you should be very careful that you should avoid synechiae as much as possible. You need to be going in. Now you see how nice it looks after decongestion. This is the middle turbinate, and this is the marking I just showed you for the extent of where I would be taking the endoscopic incision. Right, so now the same thing, I'm starting with the sickle knife, 10 millimeters above the axilla of the middle turbinate, come around 15 millimeters anteriorly, and then go down in a circular fashion around up to junction between upper 2/3 and lower 1/3 of the middle turbinate. That should be usual endpoint. And then you go back and start from behind, and don't let the uncinate process get involved, because usually that's not needed. Now what I'm doing is I'm just going and reflecting the flaps out there. The quality here is really bad. You can come and see sometimes the quality here, because the projector I think is not HD. So then I would just remove of that small circular piece of mucosa, and this is the bone that you see lacrimal. This is the maxillary ridge of the lacrimal bone, and then what I'm doing is I'm clearing the inferior most portion of it. This is where the sac would be there, and this is where the NLD would be there. So I'm exposing the entire area. Now what I'm doing is I'm taking a small bite into the lacrimal bone. This is the maxillary bone, and lacrimal bone is just behind that one. So taking a small bite into that one, and with a punch, you can do this very frequently. Nowadays I do use ultrasonic bone emulsifier to finish off this in a very, very short time. But this is what I'm showing is a standard method of doing it. This is the lacrimal bone that you see. It will be quite thin bone now. So you just need to take that out and then start punching. The extent anteriorly is till the time you start seeing orbicularis oculi. Superiorly I go up to clearance of the agar nasi. Now you can see the nasolacrimal duct here, just beneath that one. So when you're using bone punches, you should be careful not to really put a lot of pressure onto the lacrimal sac, because it unnecessarily bleeds otherwise. And you can see this is the nasolacrimal duct. We are going up to the sac duct junction now, and this is, you can see, sac reasonably okay now. So just go ahead and keep on punching. And this is the perisac tissue that you see, and then go ahead and punch. So you're actually now seeing bigger part of the sac. That's the actually going towards the fundus of the sac. See, that is a very nice sac. Now this is the anterior most extent. You should just go ahead and punch till the time you don't you really just have a glimpse of the orbicularis. So you can see how big that ostium is becoming, right? So you can actually make larger ostiums and external DCRs with an endoscopic DCR. That's just to prove that point. So going up now, this is the frontal process of the maxilla. It's up, and this portion of it, the superior most portion of it, is the most difficult to punch out, because it's a very broad base and it doesn't come in your punch. And that is the thing. This is the fundus of the sac. I'm just clearing the last portions of it. This is where the ethmoid starts. So I'm just separating a bit of the ethmoid tissue, and there you see the anterior ethmoids opened up. And then I'm going above to open up the agar nasi. Agar nasi is the anterior-most ethmoidal layer cell. There you see the agar nasi being opened up, and this is the mucosa of the agar nasi. That is very important for mucosal approximation, because if you have a mucosa to mucosa approximation, you will not allow the fibrosis from anywhere to come in. This is unfortunately not the way ENT surgeons do. This is the way they should be doing to prevent the failures. So now you can see that the agar nasi is gone, and then I'm punching a bit more. The superior most portion of it, because I want to expose the fundus of the sac. So fundus of the sac, you should see a bit of curving up there. So what I'm doing is I'm taking a small flap. This is an important flap. This is the Peter Walmart way of doing DCR. I don't do this for every patient, but this is also a very helpful step. So I'm taking a small bite of the flap and then pushing it posteriorly, and then going and punching above so that I can see the entire upper surface of the sac. Now what you see is a Medtronic drill that is being used, and I'm just drilling that portion out of it. We can use an ultrasound also, that's easier and probably a bit safer. Going again, so you can just drill as much as is required till the fundus of the sac is completely exposed. I would say the roof of the sac in this particular case. You need to be very gentle in this thing. So now you can see beautiful vascularity, and as you go down into the nasolacrimal duct, you would see a lot of sac blood vessels and venous plexuses. That's something that is very important for us. Now you can see a beautiful ethmoid here, agar nasi, and now you can see that the entire apex of the sac has now been reached. Now once that happens, you can see the beautiful vascular venous plexus around the sac, and this is the reason why when you cut it bleeds. Okay, so not an issue. You can see that the probe is coming now from the other end. But what is important is to expose this entire length of it. Now I'm using a crescent and then gently going ahead and incising the lacrimal sac. So you go and then you reflect it up, and then obviously these are the contents of the lacrimal sac. A bit of viscoelastic was used in that one. So aspirating that. And this is the stage where it is not unusual because of the perivascular venous plexus that I just showed you some time back. Taking the horizontal incisions and then obviously doing in such a way that the lacrimal sac should open like a book, and then the surrounding tissues, it should be adherent to the mucosa to mucosa approximation should be there. Now you see this anterior flap is coming over here, and this will be opposing to the mucosa. So the chances of fibrosis when there is a mucosa to mucosa approximation is very, very less. So I'm just attaching this back over here. Just make sure that it's in the right place. And then this is the posterior wall. This is the posterior wall will be attaching to the agar nasi mucosa. You can see this is the agar nasi mucosa that I opened up, and that's how it would be there. Now this was the past flap that I took initially. This I'm going to approximate in such a way that the superior area is covered, and this one comes in contiguous with the lacrimal sac again here. So here it is approximating with the nasal mucosa, here it was approximating with the lacrimal sac mucosa. So making sure that there is no cicatrix from any side. And then you can see this is very nicely, posterior flap is adjoining and in opposition to the agar nasi. So this is the fibrin glue that is being used to stick open the lacrimal sacs. Sometimes if you don't have, you can allow a bit of blood to be there, it acts similarly, and there it's being opened up now for an approximation. So allow it to stick there and let it be there. And you see at the end of the surgery, is there any bleeding anywhere? That is the significance of endoscopic DCRs. You will hardly find unnecessary bleeding that we do with external DCRs. Now see, many times we don't even pack the patient because there is no need to do that. So now allow it to be very nicely approximated. Be patient in that thing and make sure that the posterior aspect also gets approximated in every possible way. So you see everything is now mucosal line. This is within the sac that you are seeing now. So once that happens, you can go ahead, and this is the Crawford intubation that's being done. And this is the second arm of the Botkin of the Crawford. Just make sure that when you come over, do not touch the septum. Many times after intubation you sometimes find bleeding, that's because we have damaged the septum. So once this is there, you can see everything is well approximated. This is the tied end of the tube, and that's the end of it. This is I'm just trying to show every possible point where there is a mucosal opposition, and there is no point which is bare or raw for fibrosis to invade from anywhere. So probably there are another 10 minutes for me. So what I would do is I would probably take one or two questions and then move on to a very brief topic on spectrum of congenital nasolacrimal duct obstructions. Yes, sir.
It's up to 8:15, huh?
Yeah, it's up to 8:15.
15.
Oh, the time here shows 8:05, so I thought it's interactions, and since I have one or two fellows here, I would take that opportunity to harass them. All my lacrimal slides would have this. It's a tribute to all the doyens listed here and probably many more unsung heroes because of whom I'm able to stand here and speak something about the lacrimals. There's no financial disclosures of any equipment or anything that I show. So case 1. Child 1 year of age presenting with discharge and watering since birth. Samir, what would you do? Let's interact. I'm not intimidating anybody, but let's interact.
So what is age?
1 year.
1 year. So obviously, if this presenter, I would go for an endoscopic evaluation first.
Okay.
But if this facility is not available, so what I would go straight forward.
You're not saying that to please me, right? Endoscopic evaluation. You're not saying that to please me, right?
No, not please you.
Okay.
It depends on the availability of the instrument.
Mm-hmm.
If it's available, first I will go for an endoscopic evaluation
Right.
to look for the nasal anatomy.
Mm-hmm.
If it's not available, I'll take up this case.
Suppose you don't have nasal endoscopy, you're working, say, somewhere where you don't have. Can you still do a nasal evaluation?
Yeah, I can do a nasal evaluation.
How?
So, I could put a nasal speculum on the GA and I can just pass a light probe or...
What is that nasal speculum called as? Yeah, it's a 30 comes nasal speculum. Right. You can reasonably have almost up to the middle turbinate. You can have a reasonable good view with that. If you have a small light source or a indirect ophthalmoscope, you can do it. It's very, very simple. And that's what we need for pediatric. We don't need to go up to middle turbinate for pediatric patients. In inferior turbinate, which is much anterior, is what is there. So fine. So you find that things looks okay. So what would you do?
Then I would take up this case on a GA for syringing and probing.
Is the word syringing a better term?
No.
Is there a better term to use?
I'll say trick and rest.
No. Irrigation. Irrigation is a better term rather than using the word syringing. Fine. What about this? What is this showing?
Dr. Javed,
Yeah.
before people come to the I would like to do one office massage.
Yeah.
Because in the office massage in my practice, and I have got another ophthalmologist from Assam, Narayan Bardale. He does it fantastically. Just we have to occlude the common canalicular end and press it down and lateral, so that it creates a proper pressure in the lacrimal sac. And if you can keep it for 5 seconds or 10 seconds, sometimes you will hear a thud, and that's relieved. Once for all, it is relieved.
Sir, at what age this could be?
From 9 months onwards. So from 6 months onwards.
6 months onwards.
Yes.
Okay, so what I'll do is I'll take this opportunity to...
One more small
Yeah.
point. With that kind of discharge and everything sticking to the lid,
Right.
can you immediately take the patient up for examination and probing, or would you like to start on some antibiotic drops and for a day or two?
Yeah. So there's no harm in starting antibiotic drops and so and so. But over a period of time, the histopathology, which I'll shortly be publishing it, the thing that we consider as a discharge is actually this mucus secreted by the lacrimal sac epithelium. So unless it is associated with medial conjunctival congestion, if it is so bad as much as discharge and the medial conjunctiva is so wide, it just means that it is probably unlikely to be
The
doing.
parents come with the complaint that the child's eye is stuck in the morning.
Right.
There's a lot of discharge sticking.
Right.
So when you see
Right.
the patient and you want to schedule an EUA,
Right.
is it okay if you schedule it the same day or next day, or would you first treat till the discharge stops and then you would start for EUA?
If the time, obviously, for all of us who are working, it's very difficult to do it the same day. So there will be a time lag. If there is a time lag, it's a good idea to start it up. And second thing that antibiotics do also is they reduce the inflammation and have anti-mucotic effect. So the mucus production reduces a bit, because of which we have a perception that the discharge is actually reduced.
And thirdly, probably Dr. Rajesh is aiming that we are not contaminating the OT.
We have a separate plastic sewer, so nobody comes there.
But please try to do that office message for all the conditions. I mean, on your first checkup, you can relieve them.
And office message should be continued for 40 to 30 times.
No,
I
said that office massage. That is office massage is done by the ophthalmologist. Ophthalmologist for 10 seconds, and it's a magic many times.
Okay, so I'll just move on to case 2. Anirban, 28-day, I would say, baby who has come with parents complaining of swelling that's there since birth, slightly increasing.
Javed, from the looks of it, it's nanotocele or a congenital bacterocystocele.
Yeah.
Okay. One of the concerns.
Nanotocele is a better term. Amnotocele is.
But it's
so
probably
it's
the wrong term. Yeah.
Right.
So here again, I want to look at the condition of the nose because
this is how the nose
is a very large swelling which can often block off the. Okay.
This is how the nose is.
2 ways to go about it. Right. You can start with the sac massage, but probably this is the kind of patient where I would want to do a probing very early in life. Very early. Yeah. If possible, probably on the same week.
Yeah. That is an important thing. What is also very important to understand is that if at all the hydrostatic pressure that has to be generated within the lacrimal sac, if there is any condition in the lacrimal system where you can generate the maximum, this is the one. Why? Why is this swelling? Because the common canalicus has got obstructed, anyway the lower part is obstructed, and the sac has come to your visualization directly over there. So direct pressure on the sac will generate enormous amount of pressure. So if the nasal examination is normal, then it's a good idea to massage, and this is how it would appear, probably in a week or 2 weeks time.
Any other condition of the nose where massage is not advisable?
I'm coming to the third case. Similar case. Samir. Similar, and this child is 20 days old now. Quite bluish, tense swelling, quite big. You can see that the medial canthus is somewhere, and it appears the eye is somewhere pushed out now. It's quite big one. So what would you do? Quick, we hardly have any time.
Yeah.
So,
First anything,
this is what the nose shows. This is after decongestion. So, the mother has a typical history that when the child feeds with the ipsilateral breast, he chokes. So that history is very, very important of choking. Some women are very intelligent to tell you, some women may not tell you because they may not think that is related to that particular thing. It's a very important history to ask whether there is some kind of grunting sounds. But this is one way. What about the other nostril? He's lucky. But if it is a bilateral one, the child may even die before he comes to you. Okay, and there are 2 cases in the world literature where ophthalmologists have lost their license because the child died, because they sent the child on a massage back home. They did not do an endoscopic examination. Okay, so it's the significance of that the child can die with this particular thing. After decongestion, this is how the cyst is there. You can see the amount of space that it has left for the air to go. So this is an indication for marsupialization of the sac. So unless you marsupialize it, it's not going to work. What we do is something which is called as cruciate marsupialization. That's an innovation which we felt based on certain things. I do not have time to discuss that one, but marsupialize it. In case rare event that you do not have something, please do send it to your ENT colleague on an urgent basis. In the rare event, if you don't get anybody, take a large diameter of Venflon under anti-nasal endoscopy, go and puncture it out and give a firm pressure so that it gets drained through that area. Anirban, see, look at the spectrum of how the congenital nasolacrimal duct obstruction is present. 28-day-old baby.
What you have is a bacterocystocele on the left side. On the right, you already have a lacrimal abscess.
Right. What is it called as? Dactyopyocele.
Okay.
Right. This is a surgical emergency. This child will die if you do not do the same day. Okay, so that's the very significance and important. Sometimes you may not have an anesthetist backup, but do go ahead, put an endoscopy, pediatric endoscope. Obviously, for such a small child, the regular endoscope is not going to work. So have a pediatric endoscope and go ahead and drain this particular thing.
So you always refer to using an endoscope, but supposing somebody is not familiar with an endoscope, with that kind of biopsy, can they make an external incision?
Absolutely. In the event that you do not have it, go ahead, open it up. The only bad thing that will happen with that is that it will be a scar is okay, scar is not an issue, but recurrent fistulas which are terrible, so that is one important thing that's there. Anirban, a child who has a simple, like the first case which we wanted to take in for probing, and this is during endoscopic examination. Just go out and probably play once. Oh, okay. So I'll just show you unfortunately these are the diagnosis. Yeah. So this is what I'm doing. So what is happening now? What is happening now? The probe is normally passing down. So what was happening? What is that?
You have a situation where the blockage is not really in the valve of Hasner, but you have a situation which is called a buried nasolacrimal duct.
Exactly.
Okay. As a result of which, your probe is exiting at a much lower level.
Yeah.
And you would need to de-roof it.
Right. So what has happened in this one is that this particular child probe was done with two very good people who are excellent in their areas, and this is the probe very easily passes, but the child's watering has not subsided. The reason being is that the NLD is normal, there is no problem with NLD. The entire NLD is opening normally right up to there, but what has happened, it has not opened into the inferior meatus, and that's where you need to identify the thinnest portion of it, and there is a valve there. There is a depression in that area, so you should identify an area where there is a depression and just come out of that particular thing with a very simple tilt of the probe. So that's called as a buried probe. And probably the last case, this was a child who was referred with a diagnosis of dacryocele. Right, Samir? This is dacryocele. Nice. It's very difficult to contest it. Why do you think it's not a dacryocele?
Location is
More towards?
Location is much more medial and anterior.
Okay, good.
Some other pathology.
So this was what it was. So what does the CT show, Samir? What does it show? Bolo. What about this? This is the lesion. I'll help you. This is the lesion, right? But why don't I say that it's a dacryocele? Why do I not say? What is this, Samir? What is this? Yeah, that's a bony nasolacrimal duct, right? So, what does it mean? The next cut shows that lesion. What does it mean? The lesion is adjacent to the nasolacrimal duct. So it's very unlikely that the sac is normal and the nasolacrimal duct is enlarged like this. Okay, so that gives a clue. Endoscopy examination, normal. We went ahead and excised it. So what do you see here? This is the bone. This is the bone, lateral wall of the nose that was removed. This is the nasal mucosa. And what did we find? There was a bony defect downwards beneath that one. This was the histopathology. This was a lesion that was removed. And what is this? Any, Samir? Grossly, which system do you think this belongs? It's very important to be with a pathologist, isn't it? We will learn a lot of things. This is a GFAP that is there. This are astrocytes with a lot of nice processes and GFAP positives. So this was an ectopic brain that was mechanically consolidated outside the central nervous system. It was not an encephalocele. Encephalocele is another differential diagnosis that you should keep. If you felt it was encephalocele, then never go and touch it. Okay, we'll repent it. So this was an ectopic brain which was masquerading as a dacryocele, and this is already online now.
Now, Dr. Javed,
yeah,
we are on time.
Yeah, that's done. I'm happy.
I thank Dr. Javed and all the audience, whatever audience we have got. I expected some more, but my first talk still goes. Please start doing lacrimal sac surgeries, because the number.
Is Dr. Hoshan here? Alright. So I thought instead of just covering a basic talk on microbial keratitis, which I'm sure you all have heard several times, I'll cover what we see very often in our country, which is the advanced presentations. So, Dr. Rajesh Fogla from Apollo Health City will be talking about various etiologies and presentations of advanced microbial keratitis. Following which, Dr. Ramendra from Center for Sight Delhi will speak on the melting cornea, causes and therapy. Dr. Ashish Nagpal from Ahmedabad will speak on deep keratitis, which is again a very challenging condition, fungal, usually of fungal etiology, which we often encounter. Dr. Bhupesh Bagga from L. Prasad Eye Institute shall speak on multi-drug resistant keratitis. What are the management options? That's again something which we've been seeing in the last few years, and very, very difficult to treat because some of these, particularly Pseudomonas, are multi-drug resistant, and you really don't know what you can do for these cases. Dr. Hosham will speak on the paradigm shift in diffuse keratitis. Dr. Kunjal from Mumbai will speak on intrastromal and intracameral injections. Do they help? Finally, I'll be speaking on therapeutic keratoplasty, when and how. I'll give you some tips, surgical tips, as well as how to plan the procedure. I invite Dr. Rajesh Fogla to start his talk on advanced microbial keratitis, various etiologies and presentations.
Thank you, Rishi. Good morning, everybody. At the outset, I would like to thank Rishi for inviting me to be part of the symposium on advanced microbial keratitis. Well, basically in this presentation, I'll be taking you through some of these clinical situations. Are we getting this? I don't think microbial keratitis is anything interesting that people can have financial interest in. When we talk about microbial keratitis, commonly in the clinical practice we come across bacterial and fungal corneal ulcers. Often you can get viral or acanthamoeba. These are the kind of 4 common etiologies that you come across in your clinical practice. As we have been taught in our medical school and in our ophthalmology training, when we look at an ulcer in the early stage, there are certain features that help you kind of get an idea of what could be the etiology for this infection. Like in bacterial keratitis, the clinical symptoms are much more rapid, and you have this mucoid discharge kind of thing sticking to the ulcer. They are very focal, and you have a hypopion that increases quite rapidly. And some of these features tells you that this can be a bacterial ulcer. Or when you look at a fungal ulcer which has a dry-looking surface and you have these feathery margins and satellite lesions, you have a clinical idea of this can be a fungal. Or for that matter, if you look at a dendritic lesion, you know that this could be viral etiology. Or if you look at a ring infiltrate or something like a string of pearls or reed pattern, these are again classical description of acanthamoeba or nocardia. So this is where in the initial stage, sometimes looking at the clinical picture, you have some idea as to what could be the etiology. But in advanced microbial keratitis, when a patient comes with a very advanced picture, none of these features can be, you cannot look at a clinical picture and decide that, this could be the etiology in this case. And why do we get advanced microbial keratitis? I think sometimes it's to do with the type of organism. You have either a multi-drug resistant organism that has caused the infection, so that despite the initial medical therapy that's been given to the patient is not responding, or maybe you're not giving the right kind of medication. So that's where the second point comes in, that you have an inappropriate treatment. That means you may be dealing with a fungal keratitis and you think that it's bacterial and you're only treating with antibiotics and the patient does not respond. Or you have something else like an acanthamoeba or a microsporidia and you keep treating with antivirals and you have a patient that does not respond. Or sometimes you have something of a viral etiology and you think that this is something like allergic eye disease and you add steroids to the regime. And these are all things which can make the clinical picture sometimes very confusing. And often with patients with advanced microbial keratitis, we find that the patient is using a cocktail of antibacterials, antifungal and antiviral, all put together, and he's putting everything in the eye. So sometimes it's very difficult to determine what is working, what's not working, or whether it's totally a toxic medicamentosa kind of picture. And often the advanced microbial keratitis have associated risk factors like history of extended contact lens, or some refractive surgery procedure like LASIK, or even with cross-linking. If you see some of the keratitis that have happened after cross-linking usually progress to advanced microbial keratitis. or sometimes after some sort of corneal surgery when you get an infection. And because like especially corneal transplants, when patients are using steroids and you have an infection that sets in, often it progresses quite rapidly to an advanced microbial keratitis. And the other reason would be when a patient has an altered defense mechanism, either because the tear film is deficient or there is some lack of thermos or exposure. And in that situation, when you get an infection, this can, the body's defense mechanism cannot take care of it. So then again, it leads to rapid progression. Just to show you, if you look at these three clinical pictures, they all are advanced microbial keratitis. And if your clinic, if you see this picture, by looking at the eye, I don't think that you can come across as to what could be the possible diagnosis. Like the last one, although it looks like a ring infiltrate, when it was scraped, it turned out to be filamentous fungi. The first one, which although looked like a very advanced fungal keratitis, turned out to be acanthamoeba. And the second one was, like a total corneal melt, turned out to be, Pseudomonas drug resistant. Sometimes it's not just the lateral spread which fills up the entire cornea. Sometimes it's the deeper extension of the infection which is also considered as advanced microbial. So although it may be in a smaller zone of the cornea, but if it progresses deep very rapidly, it will still fall into the category of advanced microbial keratitis. And often, why these are clinical emergencies? Because a lot of these advanced keratitis, we can quickly go on to perforation, and if you don't address them at the right time, sometimes the infection can go to the posterior segment and you can even lose the eye. Just to give you some examples, now this is a 12-year-old girl, and she had a simple corneal foreign body which was removed by the primary ophthalmologist, and the eye was patched. And next day when the patch was removed, half the cornea was filled with infiltrate and had a greenish exudate from the eye. Patient was started on the 4th generation fluoroquinolone, but within 24 hours, the patient presented with this clinical picture to us. And by the time we took a scraping, we found that gram-negative organism, and by the time we could have culture report next day, this is what the patient's picture was. So we had no other option but to intervene and do a large diameter therapeutic keratoplasty. This patient, again a contact lens wearer, had some irritation in the eye, went to the pharmacy, took over-the-counter medication and started applying. And the best part was she had irritation in the eye, she had redness, she was applying some antibiotic that she got from the over-the-counter, but she continued to wear her contact lens because she didn't want to wear glasses. And finally, when it came to a point where she could not bear it anymore, this is what it presented with. So when we looked at it, again, this was a scraping done. We found that again it was gram-negative organism, treated successfully. Again, this was again, like I showed you, that this was a patient, looked like a ring infiltrate. Clinically, when we looked at it, we thought, okay, this must be acanthamoeba, it's a very long-standing and not responding to medication. But when we scraped, we found filamentous fungi, and this took a long time, almost 2 months of therapy, and finally we could get the ulcer to heal. Corneal transplantation, any infection happening is a advanced microbial keratitis, even if the infiltrate is small. Why? Because you have a patient that's already been on steroids. And if you get an infection, first thing you have to do is to stop the steroids. So if you don't treat the infection early enough, you can lose the graft. So any small infection in the presence of a corneal graft is termed as advanced microbial keratitis. This is a patient who had again an infection, treated for a long duration of time, and this is acanthamoeba. So sometimes when you are treating advanced microbial keratitis, you should not allow the infection to reach up to a stage where later on, even if you do a surgery, you may not be able to salvage the eye much. So the decision to intervene surgically also has to be at the appropriate time. This is a patient again was treated as fungal, then as viral, and people did not have a diagnosis, and patient had waxing and waning symptoms. Both the cases are 2 different cases, and they had microsporidial stromal keratitis. So the thing is, in this presentation, what you have seen is the very clinical picture, what you see when you have advanced microbial keratitis. And I think it's not appropriate that when you see a patient with advanced microbial keratitis that you still take a clinical judgment and start treating based on what your gut feeling is. I think in advanced microbial keratitis, you need to have a definitive diagnosis. And sometimes if a patient is on a lot of medications, sometimes it helps to stop all the treatment for a day, just put the patient on some cycloplegics and lubricants, and then maybe do a microbiology. Otherwise, if you just do a scraping, sometimes you will find that neither does it show anything on the smear, neither you get anything on culture. And for me, my threshold of doing a biopsy in such kind of cases is very low. because I know that patient has been treated with so much of antimicrobials that usually on the surface you may not get any specific diagnosis. So treat it as an emergency, take a biopsy, get a diagnosis. Biopsy I always divide into two halves, because sometimes it takes a long time to grow in the microbiology. Sometimes the histopathology pathology can give you some idea as to what you're dealing with, especially when you're treating with acanthamoeba or you're dealing with microsporidium. So basically, for advanced microbial keratitis, the etiology cannot be assessed based just on the clinical presentation. Although sometimes the history may be, helpful. But still, then, so let's say somebody has a history of contact lens wear. It can be bacterial, it can be acanthamoeba. Sometimes it can even be fungal. So just based on history alone, that somebody has a trauma with a, vegetable matter or tree branch, and you say that this is fungal, that's not correct. I think here in advanced microbial keratitis, having a microbiological diagnosis is very essential, because you are at a state where the cornea is almost involved, and if you don't treat appropriately, you can sometimes lose the eye. Even if you were to do a therapeutic keratoplasty and you don't send the button for microbiology, you can have a recurrence of infection in the post-operative period if you don't know what was the primary infection that led to that picture. So very strongly recommend that the appropriate diagnosis requires microbiological investigation, and in most of these cases it requires surgical intervention. So that's a short presentation on advanced microbial keratitis, the various etiologies and the clinical presentation. I invite you to our second national meeting of Cornea Society of India, the Keracon 2014, that's in Mahabalipuram, 20 to 21st December 2014. More information on the webpage, corneasocietyindia.org. Thank you.
Often it leads to ocular morbidity and profound visual loss. It could be the end result of various infectious or non-infectious etiologies. For example, microbial keratitis, trauma, autoimmune disorders, and ocular surface related disorders. And here we need to intervene immediately to preserve the anatomy of the eye and to prevent complications as endophthalmitis and secondary glaucoma. And management can vary from temporary measures such as application of bandage contact lens with glue, or definitive measures such as corneal transplantation. So as I said, the various causes for the corneal melts could be infectious. Here we would be dealing mostly with the infectious causes, the non-infectious, which are ocular surface related or autoimmune, and traumatic. So amongst the infectious corneal perforations, the bacterial and the fungal infections are the most common causes in the developing countries, whereas recurrent HSV keratitis with stromal necrosis is the major cause in the developed nations. So talking about bacterial keratitis, Pseudomonas infection is a very important cause for the corneal melts and perforation. Here the cornea has a ground glass appearance, and there is relentless progression of the corneal thinning and acute onset of perforation, and the cytokines which are released because of the inflammation lead to corneal melting even after the bacterial amplification stops. Often these eyes have a poor prognosis, and the other organisms which have been implicated amongst the bacterial infections are Proteus, Streptococcus pneumoniae, Moraxella, and Salmonella. A study from North India has found that the leading causes in bacterial keratitis which lead to corneal perforation are outdoor occupation trauma with vegetative matter, central location of the ulcer, lack of neovascularization, monotherapy with fluoroquinolones, and failure to start timely management. And in this study, they found that that Staphylococcus epidermidis was the commonest organism which was isolated. Talking about viral keratitis, the herpetic corneal disease, especially recurrent HSV keratitis, leads to progressive corneal thinning, and the stromal necrosis leads to melting of the cornea, and it could be because of the replication of the virus, and also because of the immune response by the host, which leads to corneal perforation. There is a release of MMPs and collagenases from the polymorphonuclear cells and the macrophages, which lead to corneal perforation. In necrotizing stromal keratitis, the epithelium breaks down over a dense stromal infiltrate, and because of the release of the cytokines and MMPs, there is perforation. And sometimes because of overuse of topical steroids in HSV keratitis, and also because of toxicity, because of too much of antivirals, the perforation can happen. Fungal keratitis is an important cause of corneal perforation in our scenario. Almost 1/3 of fungal infections require surgical intervention because of treatment failures or corneal perforation. The fungi which are mostly associated with corneal perforation are Fusarium, Aspergillus. Sometimes demitatious fungi such as Curvularia also lead to perforation. Now, the rate of corneal perforation in various studies, they have shown the rate ranges from 4% to 33%, and Lalita et al. Have reported a perforation rate of 61% perforation in fungal keratitis with treatment failures, and overall 19% perforation rate. The routine lab diagnosis, you need to be very gentle. When a melting cornea presents, you need to be very gentle with your corneal scraping. And the corneal scraping should be sent for grams, calcoflow white, chocolate agar, SDA and thioglycolate broth cultures. Full systemic workup of a patient who presents with corneal melted perforation is very important, and you sometimes need an internist help. Sometimes you need to rule out any other associated autoimmune cause. Even if it's an infectious keratitis which is leading to a corneal melt, you need to rule out other associated collagen vascular disorders like rheumatoid arthritis, etc. to be sure that the patient is not immunologically compromised or any other collagen vascular disorder is present. Sometimes you need to adjust the dose of the immunosuppressives also. So management starts from non-surgical management. You need sometimes with a perforated cornea or a melted cornea, you need to put the patient on oral antibiotics. In HSV necrotizing stromal keratitis, you need to put the patient on oral antivirals. Sometimes anti-glaucoma drugs are necessary to prevent the extrusion of the intraocular contents. Anticollagenases play an important role, like oral doxycycline, acetylcysteine, topical also help to prevent the melting of the cornea. Anti-inflammatory therapy, once the infection is under control, you can put the patient on topical steroids and cyclosporin. You need to optimize the epithelial healing. The patients, you should need to put the patient on preservative-free lubricants. You need to promote epithelial healing to prevent the melt. Punctal plugs or intracanalicular plugs, they prevent the drainage of the tear and maximize the contact of the drugs with the ocular surface, and they can reduce the dependency on tear supplements. Now, talking about surgical management, the first and foremost thing which you need to be ready with is the gluing. That is the cyanoacrylate glue, which is very cheap and easily available and very easy to apply. So any patient who walks in your OPD with a melting cornea or a perforated cornea, you can't just send him away without gluing him. And these glues have traditionally been the most widely used glues for ophthalmic surgery. They require minimal hydration to polymerize and set, and the tensile strength is very great. So even a perforation which is up to 3 mm, it can hold on very easily with a glue. And it has antimicrobial properties also. It has antibacterial and antiviral properties, so it can actually arrest the progression of the melt. So what are the indications of cyanoacrylate glue? Corneal perforations up to 3 mm, corneal melts, impending perforation. Even if you get a patient with 80% thinning or 90% thinning, glue him before the perforation sets in, so that at least you will get away with a secondary glaucoma or an endophthalmitis. Once the perforation has set in and there is relentless progression, then nothing much can be done. So even when the cornea is around 80 to 90% thinned out, you can glue the patient on the same day. In wound leaks, Moran's ulcer, margina, these are other indications apart from infected keratitis. One important thing when you glue a patient is it is essential to debride the epithelium and necrotic stroma before you glue the cornea for firm adhesion. This is one post-op patient. Some of the patients in infective keratitis, this is the pre-op picture, the post-op after gluing. See, the AC is now formed, and now I can hold on easily for 2 to 3 months, let the cornea scar, and later take up the patient for an optical graft. Another patient, this is almost 90% thinning with impending perforation, and this is after glue. This is a patient who presented with a therapeutic graft. It was done elsewhere, and the graft had started melting away because of recurrence of infection. When the patient came to me, I just didn't want to send the patient back. I wanted the infection to settle down and then take him up for a second therapeutic graft. So I glued him the same day and sent him back, and later took him up for a therapeutic graft. Of course, peripheral ulcerative keratitis is an important cause of gluing, but here we are more focused towards infected keratitis. So here is one patient of Moran's, and this is the peripheral ulcer which has been glued. आगे नहीं बढ़ रहा है. So I'll just show you. This is a patient. You need to debride the epithelium thoroughly. You need to remove the loose sutures. This is a patient who presented with a melting therapeutic graft, and the central cornea is all melted away. And this is how you do the gluing. Gluing can be done by disc technique or drip technique. I usually follow the drip technique. I use a 26 gauge or a 30 gauge needle on a 1 mm syringe, and I completely dry off the surface. And then I'll gently put 1 or 2 drops. You need to be very, very careful while putting the glue, because very little amount needs to be put, because it immediately solidifies and expands to almost double its volume. So the lesser amount you put, the better it is. And let it dry completely. It takes around 2 to 3 minutes to dry up. Then you put a bandage contact lens over it. So this is how gluing has to be done. And it is a very important tool for the cornea specialist. Almost in my OPD every day I glue 2 to 3 patients. Now fibrin glue also is an important tool, although it does not have as much of a tensile strength as the cyanoacrylate glue, but in certain conditions like persistent epithelial defects, corneal thinning, etc., you can glue with fibrin glue also with a amniotic membrane. So whenever I use fibrin glue, I usually combine it with an amniotic membrane graft. So fibrin glue, as you know, has a fibrinogen component and a thrombin component, and then once you combine them, you get fibrin, and which is very, very biocompatible. It degrades over a period of time, and unlike cyanoacrylate glue, it does not incite inflammation. It leads to a lot of post-operative comfort for the patient, and it forms a smooth seal around the entire length of the wound edge. So, but the only disadvantage is it does not have as much of a tensile strength as the cyanoacrylate glue, and it also can sometimes lead to the transmission of prion viral disease. That is just a theoretical hypothesis. So it also does not have bacteriostatic effects. You can also have conjunctival flaps to aid in the healing of the melts and the corneal thinning, and it brings in the superficial blood vessels and helps in the healing of the melts. Amniotic membrane transplant, as I said, helps in the healing of the persistent epithelial defects, thinning of the cornea, and you can compound it with fibrin glue, and you can put it with also either fibrin glue or with sutures. You can use a multi-layer graft or you can use a single layer graft. Usually I use a multi-layer graft for thinnings, whereas a single layer graft for a persistent epithelial defect. This is a persistent epithelial defect patient. Here I put a purse string suture and with amniotic membrane also along with fibrin glue. You can also do an augmented amniotic membrane transplant where you can put multiple layers of the glue multiple layers of the amniotic membrane stuck over each other with fibrin glue and anchor finally with tenno nylon. Here you can see in the lower picture, this is a multi-layer amniotic membrane graft for a corneal perforation, and it has just been put with fibrin glue. So corneal, in large perforations, when the diameter of perforation is more than 3 mm, you cannot simply just leave it with the glue. You must do a tectonic surgical procedure like a patch graft. The patch graft could either be a lamellar patch graft or it could be a full thickness patch graft. So, like in this patient who had an inferior corneal melt with iris prolapse, this is a patch graft. It's a full thickness patch graft which has been done here, and this tectonically saves the eye. In a large melt with a large perforation, of course, a therapeutic graft only will suffice. So corneal perforation results from a variety of infection and non-infectious disorders, and you need to address various issues like the infective component, the neurotrophic component. You need to treat the ocular surface. Small perforations can respond to gluing, whereas larger peripheral perforations can be managed best with tectonic grafts or amniotic grafts or tectonic keratoplasty, and sometimes you even need to do a therapeutic transplant. Thank you. So I'll invite the next speaker, Dr. Ashish Nagpal, for his talk on deep keratitis, a management nightmare.
Similar topics, similar. My focus is purely on deep keratitis, which sometimes becomes a management nightmare for all of us. I'd like to acknowledge the help of Dr. Somashila, Dr. Rishi and Professor Namrata for helping me in this presentation. So I think a lot of points have already been elucidated by Dr. Fogla, that any deep, if you have a patient with microbial keratitis, the principles remain the same even for a deep one. The only first thing we need to do is to establish a diagnosis, initiate medical management. But in these deep keratitis, you also need to start thinking early of doing some adjunctive procedures, maybe like an AC wash, giving some intracameral injections, and if that is not possible or not responding, we might need to go in for surgical management earlier. So this is what we need to keep in mind. So just to give you a brief overview, these are superficial mycosis. As you can see, these patients, once you establish the diagnosis on KOH or culture and start medical therapy, and they start responding with scarring, they do not go in deeper. These are very, not very easy always, but these are fairly easier to manage as compared to the deeper ones. But there might be certain very progressive fungal ulcers which might just progress in front of you, or even as Dr. Fogler showed in his presentation, some bacterial infection will progress very rapidly and they might melt. But classically, I think fungal is one thing which we tend to see a lot more in our country, and they tend to form deep abscesses because of the nature of the fungi. It does tend to penetrate deeper inside along with going centrifugally. Having said that, at the same time, you might have a similar looking which we consider as this ulcer looks like fungal, but it might not be fungal. It looks like a diffuse hypopion and this. So this is where we need to establish the diagnosis. In such a case, if the ulcer has a superficial component, it's easy. One can scrape it and send it to the microbiologist and establish a diagnosis. But this is a clinical picture of a gram-positive cocci infection. A fungal infection, a deep one, can look like this as well, where you don't know what to do. How do you establish a diagnosis? Because there's nothing on the surface. How do you scrape it? In such cases, you would need to do some other procedures, other newer investigations, which if you have access to, which I'll be talking to in a few slides later. And some cases might be scarring superficially, but might be having a deeper component, an endothelial abscess. So again, these are very difficult because the drugs only go in so much more, and they might end up with a perforation eventually. And this patient required therapeutic graft, and you can see the perforation even on the cross button. So coming back to the mycotic keratitis epidemiology, I think fungal ulcers are far more common in our part of the world as compared to what is described in literature worldwide otherwise. And there's almost a difference of almost 17 to 40 to 50%, I would say, ulcers can tend to be fungal. And this is just a snapshot of the culture positive cases at our practice in 2000, which we had done in 2003 to 6, and you could see almost 70% of the ulcers referred to us or came to us were fungal. And of these, again, further, most of them were fusarium in our part of the country and aspergillus. So, like the previous case which I had shown you, which was only a deep lesion, then you need to have certain, in those cases, if you have access to confocal microscopy, then it might be of use to you. This is what the fungal filaments would look like on the confocal, and then maybe you can initiate treatment accordingly. Certain other infections like acanthamoeba can also be diagnosed well conclusively with the help of confocal microscopy, but the only two limitations are the availability of the confocal and the expertise to do the confocal, because you need to be well versed, you need to know what to look for, you need to know what to see. So if you have access, then in such cases would benefit from these investigations. Otherwise, the only other option is probably to do a corneal biopsy. And in such a deep lesion, you need to go in, maybe create a trapdoor kind of a pattern, remove a part of the infective infiltrate and send it for histopath and microbiology. Like in this case, this patient was not responding, and they did a biopsy, and then they could see the fungal filaments, and then eventually they started treatment, but they still did not respond, and it required a therapeutic graft. So amongst the available antifungal agents, we have this whole list, which is some of them are available to us: natamycin, amphotericin, and now voriconazole and itraconazole as well. But and this is the standard procedure that we would start. Topical antifungals would be a 5% natamycin hourly, even in all these lesions, and then you gradually taper after 4 to 7 days interval after assessing the response. And if it keeps worsening, then maybe you can add another antifungal. Some people prefer to add amphotericin, especially if it's an aspergillus infection, and one can also use voriconazole because of maybe it might have because it works differently, it might have a better effect using natamycin and voriconazole, especially for the trial for these deep infections. But the limitations are the same. They are some of them might not be available commercially. They have poor ocular penetrations, natamycin especially, which works the best as a suspension, and they have poor bioavailability, and sometimes the patient don't like to use those drops because they cause more inflammation. It's very difficult to put a suspension 1 hourly, half hourly, especially when you already are in pain. So sometimes they might not be putting it, they might not be compliant. So these things are the limitations of these antifungals. And so that's why fungal keratitis is always a therapeutic challenge because of all these lesions. And they might require something else. We need better drug penetration. And of course, voriconazole has come in, but it has limited use. I think this will be touched upon by Dr. Kunjal as well in the presentation on intracameral and intrastromal injections. But when to use in this deep keratitis also is an indication for using systemic antifungals as well. And there are various drugs available. We prefer, you can use ketoconazole, fluconazole, itraconazole. There are no conclusive reports as to which one would work better. So sometimes we just empirically use ketoconazole or fluconazole. Some people prefer itraconazole, but itraconazole also we are able to give topically with the available drugs in India. So you can do a multi-drug therapy for such cases if you want to do. But the important thing to remember is that if these patients are on it for a longer time, you need to make sure you do a baseline liver function test and also repeat it every 2 weeks and ask for symptoms like anorexia, etc., because they might be having some problem with the drug itself. The important thing here, I think, which I want to highlight is the debridement. Repeated debridement on every visit, removing the epithelium would help a lot even in these deep keratitis cases for the better penetration of the drug, and this would be useful. The other aspects will be discussed in the next presentation. This is just to highlight the use of intracameral amphoby, a patient in which we did use and 2 months later it did scar down. So it has a role, but not always. In such a case as well, one can do an AC wash, remove the toxic material, infiltrate, and it might be helpful in terms of debulking, removing the fungal load as well. That might help us and nature both to heal the infection. But not always. Some patients will not respond despite all these efforts, and they would require a surgical intervention like a therapeutic keratoplasty. So to summarize, I think establishing diagnosis by whatever means you have available, either scraping, if you can go ahead and do a biopsy, if you have access to confocal, you can use all these resources first to establish. You should not be unsure whether if you don't know what it is, if you start using all the drugs, I'm sure it won't be as useful. Intracameral drugs, they definitely have a role in these deep keratitis lesions after you establish the diagnosis. But important thing would be to have a very low threshold for surgical intervention in these deep keratitis. If you're not able to establish a diagnosis, not able to do a biopsy, I think it's best to go in surgically and remove the infection. Thank you very much.
I think there was a very good point that you made in the last, to have a low threshold, because most of these deep keratitis are fungal, and if you take them out well in time with a good margin, sometimes you can get an optical result with a therapeutic keratoplasty if you use a good tissue. So I think particularly when you're dealing with the fungus, if you start seeing some response within a couple of weeks, well and good. Otherwise, don't wait for it to become too large, because then sometimes you might have missed the bus.
So for how long can we use systemic antifungals?
You can use them for a couple of months also, as long as you're checking the liver function tests every 2 weeks. But if it's not responding in a month's time, then you really have to do some kind of surgical intervention. I'd like to now invite the next speaker, Dr. Bhupesh Bagga. He's a young surgeon from M.V. Prasad Institute and a very good surgeon. He'll be talking to us about a very difficult entity, multi-drug resistant keratitis. We do see this every now and then, and these are the really challenging patients to treat because the infiltrate may be okay, but it just won't respond to your drug. What do you do?
Good morning to everybody, and thanks Dr. Rishi for giving me the opportunity to speak in this course. As Dr. Rishi already mentioned, that this is a very difficult entity, and treating a microbial keratitis with medically which a bug which is non-sensitive to any of your routine antibiotics, it is really nightmare. And as a cornea specialist, as an infection specialist, you should be aware that what are the options available with you, and when to refer the patient, and when to do surgical management, and what are the really they are challenging, or just we are thinking they are challenging. So I will touch in my 9 to 10 minutes talk about what are the really incidents worldwide, Indian incidents, what are the few outbreaks which you have encountered in recent 2 years in our community, how we manage them, and what are the options available for us, and what should be the protocol for these MDR bugs. I have no financial interest in any of the products mentioned in my presentation. So I will start my talk with a case who is 66-year-old male and who has undergone SICS with PCIOL 3 months back. Was referred to us by a team of ophthalmologists. His patient was on antibacterial, antifungal. There was no organism at that time because they have done even endoscoping, intrastromal antibiotics, intrastromal voriconazole. But when it's not responding, then it was sent to us. And as everything was done, and patient was still post cataract surgery, and but the B scan was showing hardly any echoes. We thought only we'll go with penetrating keratoplasty or patch graft, and we'll see what organism is. So we did patch graft, we did penetrating keratoplasty of this patient, and this patient was doing well. This patient is doing well. Is now a 1 year old. 1 year follow-up is over, and we revealed the organism of Burkholderia cepacia, which was resistant to all antibiotics. So, like this type of organisms will give you a challenge when you encounter these type of conditions, particularly your iatrogenic cases, status post cataract surgery, status post graft surgery. So, what is MDR? There are few terms which are reported in literature: MDR, XDR, and PDR. Just to make it very simple, that if it is non-sensitive to your routine antibiotics, or maybe basically at least one agent in 3 or more antibacterial agents, then you will make it as a MDR. If it is extensive, then you can make it basically to at least 2 group of antibiotics, and PAN when this is not sensitive to any of the group of antibiotics. One more definition which is of very important use for us is a MRSA. What is HA MRSA? What is CA MRSA? HA MRSA is hospital acquired MRSA, and CA MRSA is community acquired MRSA. HA MRSA is basically, or a hospital acquired MRSA is definition by is when infection is identified after 48 hours of admission to a hospital, or you get a definite history of hospitalization, surgery, dialysis, residence in long-term care facility. Actually, this is not for us. This is for systemic care doctors, but definitely is relevant for us also. We use therapies in our routine patients: sulfonamides, macrolides, aminoglycosides, polymyxin-based combinations, fluoroquinolones, cephalosporins. That is our routine teaching. We have been taught to use all these medications in our microbial keratitis patients, and we definitely should do all these microbial keratitis patients microbial workup to see the culture sensitivity. That is helpful to manage in our patient in a more scientific and more stepwise manner. But resistance is there. So there are many papers. Since 10 years we are seeing, maybe more than 10 years, we are seeing emerging resistance to every antibiotic, because bugs are more smart than us. Whatever antibiotic you give them, they will develop resistance with any other antibiotics. We develop 4 generations fluoroquinolone. There are reports of 4 generations fluoroquinolone resistance. We develop resistance to all quinolones, whichever you offer to them. Develop which are you seeing the sensitive drug for MRSA is vancomycin. Now you are seeing VRSA. Now you are getting linezolid. Now you are getting LIC, LRSA. Now everything is, whichever antibiotic you give, they will develop resistance to that antibiotic. So in this paper you can see, this is not a recent data. I will show the recent data in my next slides. This is the data from 91 to 97. You can see that insensitive mouses. The insensitivity is increasing from 3 to 70 to 25% to 31%, 34% is not remarkably increasing in these 91 to 97, but definitely slowly resistance is increasing. And the susceptibility of organisms is decreasing in keratitis, endophthalmitis patient, conjunctivitis, blepharitis patient from 93 to 2001 paper, as you can see in this paper by MAHF et al. This is our LVPI data. Yeah. So this is, I will discuss about three most important organisms which we have encountered resistance, and this is one of thesis subject from my fellow Dr. Ratnesh Sharma. I perceived from him that this is the data from 3 years. We encountered 193 cases of MDR pseudomonas, and don't get surprised, don't get so much you can say disappointed by the data 193, because of two major epidemics occurred during this. That's why the data is so much showing so much number. So our all patients are mostly 58% of status post ketoplasty, 7% status post trauma, and 25% patient of ocular surface disease. We managed medically 173 patients, but 20 patients undergone surgery. Out of them, 17 therapeutic ketoplasty, and 3 was so bad that we need to do evisceration. Out of them, the sensitivity pattern, if you see of MDR pseudomonas, most common antibiotic sensitivity is colistin and imipenem. Piperacillin, tazobactam are sensitive, but definitely the best antibiotic. So based upon this, we made a policy that for MDR pseudomonas the best drug is colistin or imipenem, but definitely you should go for sensitivity because few patients are sensitive to your Ciclox also. This is the trend of MDR pseudomonas in our institute. From 2008, 2009, 2010 it was increasing, but 2011 and 12 when the epidemic occurred, it was almost reaching to 90 cases per year, and 2013 by God grace it's going down again to 40 and stable as come 2010. So resistance pattern, if you see from 2009 to 2012, 49% of these pseudomonas works are resistant in 2009, while in 2012 they were 70. So we did study in 2006, 2008 about MRSA and MSSA. We collected 199 cases of Staphylococcus growth, and we see the trend of increasing resistance year by year. And the good thing is that MRSA versus MSSA clinically they are not very different, but the sensitivity wise, we said that you see the getifloxin having nearly equal sensitivity in both MRSA and MSSA. ORSA is oxacillin, which is commonly used for this type of test, but getifloxin is the better drug in cases of MRSA. But vancomycin, if you see the 100% sensitivity, the 0% resistance encountered in MRSA, that is a good drug still. So all are sensitive to vancomycin. One outbreak of MDR Gen-B, MDR Burkholderia cepacia, which I think AIOC also sent a warning about that epidemic. This was referred from a single surgeon, and it was a 22 eyes with clear corneal incision, and he presented after 99.5 days approximately. These all 21 cases, like we saw all these cases around 3 cases per day, these type of cases, and they were all resistant to all antibiotics except meropenem, piperacillin, imipenem, and average of 44.1 days of treatment with topical antibiotics were over when we came. So there no response, and this is all collage of all these patients. If you see, all 21 patients having deep stromal infiltrate, and the localized and the clear corneal superior tunnel, and they're all deep-seated. Patient was on steroids, patient was on all meropenem drops. So we did culture of that particular drop, procarocanide drop, and we did culture of the biopsy which we have taken in all these patients. All species are same, even the genomic studies we did same, antibiotic sensitivity are same. This is the histopathology of the same button. You can show the deep-seated infection in this group of patients, and this is a collage of all patients having undergone pediatric ketoplasty, 2 patients, and all 19 patients had gone patch graft. So management options, I would say the 3 most important thing for everybody that should recognize of existence of resistance, prevention of occurrence, and treatment. For recognition, you should have high suspicion of iatrogenic cases. If your patient is being treated for your you have done surgery, or being treated for your ulcers, or being treated for your graft, and that develop infection, you should be clear that maybe a patient is having resistant bug. Check for antibiotic susceptibility in all cases, and to assess the clinical response carefully. Can I have 2 minutes more? Okay. So, prevention of occurrence, this is for very important, the most important slide I can say, to avoid injudicious use of antibiotics, follow guidelines of their use, and to treat based on microbiological reports. And you should be having targeted therapy. It means if patient is having gram-positive cocci, it should not be continued as gram-negative bacilli treatment. Patient is having fungal, even then you are continuing 1 hourly antibiotic therapy. If patient is having gram-negative bacilli, you are continuing with fortified cefazolin for 1 month. Definitely you are inviting trouble for you and you are inviting trouble for community. I think this is the most important slide if you can prevent. But resistant and medical management, these are the few tips which are very important in management. Resistant and sensitive bacteria are clinically indifferent. You cannot say, if somebody is saying that this is a resistant organism, I think this is a wrong statement. They are mostly indifferent by their clinical behavior. Because they are not responding to your routine antibiotics, that's why they are coming in more virulent form. You are saying so much toxin, so much cornea is hazy, large infiltrate, that must be resistant. No, because the bacteria is like that. The behavior of normal bacteria will be same, but they are different in their management. To start with therapy based on smears, observe carefully the signs of resolution. Carefully means you should see definitely a careful signs of resolution. Check for culture report. If worsening on your standard antibiotics, think of resistance. Get extended spectrum sensitivity also. Extended spectrum means you should not only check for quinolones, not only check for aminoglycosides, you should go for imipenems, colistin, piperacillin, tazobactam for all these bugs. We have presented this paper in New Cornea Congress. 4 patients responded to colistin eye drop and 2 to imipenem. This is option for MD organism. I think this is good for you to note it, or I can mail this slide to you, how to prepare your drops from systemic injections. And these are the 4 commonly used medicines which we use. So surgically management wise, there should be a low threshold for surgical management because of the high virulence only, because you have given enough treatment for these bugs, and by the time the patient presented to you, the organisms can maybe have reached to deeper also. Vegetarian ketoplasty is the mainstay, and look for extensive involvement. One more outbreak, if Rishi permit, just one more slide. Basically, this patient presented with a clear graft after ketoplasty for fungal keratitis. Developed rejection. We started intensive steroid and lubricating gel. This patient presented within 3 days with extensive corneal involvement. Other also presented like that. So we cultured that gel, all the drops, and we grew that grew gram-negative bacilli, and both were MDR, means from cornea and lubricating gel. So that is also sensitive to colistin, imipenem. The rest all antibiotics were rest all inpatient. Meantime, around 3 patients were resistant to all, that is pan-drug resistant. So for conclusion, increasing trend of oxygen-resistant staphylococcus. In quinolones, gefloxacin and moxifloxacin are better, but should be used very judiciously than others. Vancomycin is drug of choice for MRSA. Increasing trend for MDR pseudomonas infections. You can rely on colistin and imipenem, but early surgical intervention in case of recalcitrant keratitis is the key. Thank you very much.
Thank you, Bhupesh. I think that was a fantastic talk, and there was a lot of learning for all of us. Just one query I had. There's 2